start by asking you about your journey into medicine. How did you decide to become a physician?
Well, I don't know I ever started out with an ambition to be a physician and a surgeon, but like so many people, I found my way there. My parents were both school teachers, but there was some heritage of medicine in the family. I had particularly an uncle who was a general practitioner, a GP. And as a child, I used to go down the country to stay with them. And I remember going out and sitting in the back of an old Wolseley car. I don't know if anybody would remember the Wolseys, but they were back in the 60s. And so we went out and did house calls. And I remember sitting in the back and just feeling good about it. And I guess that's really what motivated me to consider medicine. And then as I went through college, I was fortunate to be with a group of friends who were really very formative in terms of our friendships. And quite a few of them ended up doing surgery, as I did. But I think the thing that brought me to surgery was doing an elective period. I went to, again, a country hospital where there was the county surgeon in those days. And it was remarkable what was achieved, what was done. And you just felt good about being able to help people. I was also good with my hands, and there was a certain appeal about being able to use your manual skills. But there's also an algorithm in surgery which you come with somebody who's got a problem and you work through an algorithm. But at the end of that algorithm, there's a decision to operate. And physicians might like me saying it, but you can always change the color of the tablet, but you can't undo the incision. And so there really is a decisive interaction, and that also, in a way, appealed to me.
I also find myself thinking about the physician-patient relationship in surgery. What observations do you have about the evolution of that relationship, or how has it come to be defined for you?
Well, it's a very intimate relationship. And you lose sight of that intimacy, and I mean that in the purest sense, at your peril. And I think I got the greatest insight to that when I personally had surgery. And I had to actually sign a consent form which allowed somebody to put me asleep. I had loss of autonomy, and I had to have a confidence in the ability and the integrity and the resilience of the person that I had entrusted my own problem to. And I think I respected that. And one of the interesting things as a professor of surgery I used to teach was I thought the process of consent is flawed, asking somebody to give their consent. Your relationship with the patient must be such that the patient actually asks you to do the procedure. So a consent form, in my view, is actually the wrong term. It should be a request form. And that implies that the individual has not only the information about the risks, benefits, and alternatives, but also has the confidence in the person they're asking. And that's it's an interesting concept, but I think it addresses your primary question.
You know, I find myself thinking about the span of your career and the tremendous changes and progress that you must have seen. And I wonder if you could talk about some of the positives.
Well, the biggest change in my career has been actually the diagnostics. When I started out, if you can imagine, we didn't have CT scanning. MRI was some kind of experimental thing. So ultrasound was what we used, barium X-rays. Endoscopy was in its infancy. And I look back, even medical treatment, the standard treatment for hypertension was a drug called methyl-dopa that I think is back in the, in the Stone Age. So that's the huge change. And when I started out, we used to do things called exploratory laparotomies because we knew there was something amiss, but we didn't know what it was. In the last, certainly decade of my life, we never went in without knowing exactly what was needed. That's coming on apace because we will have image-guided surgery. We will have extraordinary advances in terms of oncological surgery where there will be antibodies to the tumor cells that will then be linked to some fluorescence, and we'll be able to see exactly where the tumor is without having to send it for frozen sections and things like that. The downside, the downside is people are living too long. In my time, the average life expectancy in Ireland, and I'm sure it's the same in Canada, has gone from 72, 73 up to 84, 85. And we're now living we're working with individuals whose comorbidities a decade or 20 years ago, they wouldn't have survived. So it was the greatest challenge for me in the last decade has been the comorbidities that I'm dealing with, not the surgical challenges. And secondly, the expectation that no matter what, there was also always going to be a solution. So I think those are the two difficulties, the comorbidities and the changes in expectation. But I look to the future and it is with wonder we look to the future. If you can only think of the advances we've had, even in the last 10 years, where robotic surgeries become routine, laparoscopic surgeries become routine. The problem is who's going to do the open surgery, because occasionally it's needed.
When we create these podcasts and these visual interviews, we know that part of our membership are younger career physicians, those who are still completing their training. And I wonder, as you look back at your career and as you look at what might lie ahead for those young, perhaps surgeons in training who may follow in your footsteps, what are some of the most enduring pieces of advice or counsel that you would offer them if asked?
Find a mentor, a role model, and be guided by him or her. I've had the privilege of working with some of the training with some of the technically most gifted surgeons I've come across. From a surgical standpoint, there are many, many attributes needed, but at the end of the day, you need technical prowess. You need to be able to do your technical best. And one of the more interesting pieces of data that's now emerging as the profession, and particularly the surgical profession, is becoming more gender balanced, is that there are data now that show that the outcomes from female surgeons could possibly be better. And when you actually do drill down into it and do analysis, it's that ladies tend to operate a little bit more slowly. So you need the eye of an eagle, the heart of a lion, but the hands of a lady. You know, you mentioned mentorship and the importance of finding mentors. And I wonder, again, at this moment when you're reflecting back on your career, is there one mentor who stands out in your mind as having imparted particularly important lessons that you've carried with you throughout your career? Well, I was very fortunate as a young trainee to work with the Professor of Surgery in Trinity College, where I graduated, Tom Hennessy. Professor Hennessy was a big surgeon in terms of the work he did. He was an esophageal surgeon in the days when esophageal surgery was fraught with risk. But I remember he said to me one day, he said, you could make $1 million, he said, in private practice. But you, he said, will make $500,000 in academic practice, and you'll be happier. And that actually has stood to me. I've thoroughly enjoyed the opportunity of mentoring, training, bringing 25 trainees through higher degrees, training over 50 senior registrars in my time. And that's probably the most rewarding thing, is to see somebody you've trained and mentored being highly successful, in fact, being better than yourself.
Now, throughout your career and your area of surgical expertise, I mean, you must have seen so much suffering on such a consistent basis. And I wonder, when you look at that exposure to the human condition and human experience, and also just the difficulties that you must have encountered physically and emotionally that are inherently part of our medical practice and medical life, what do you think, looking back, has helped you maintain perspective or balance? What attitudes or skills or outlets have perhaps been most useful to you?
I think I've been blessed with a very stable and happy family life. And I think that's kept me focused. I think if you have empathy and understanding with your patients, yes, I have seen suffering. The most difficult thing ever is to tell a parent that their child has been killed, or I mean, those are scars that I will always telling a mother that her child has been killed in a road traffic accident is just heartrending. But I think I've been fortunate to have had the support of colleagues, but particularly supportive of my wife and family.
Now, as we look ahead and sort of what we've just been through in the last few years in terms of the acute phase of the pandemic, we are at a stage where we are experiencing record numbers of burnout, where many of our younger colleagues and our peers are questioning how much longer they are going to last, maybe even privately or publicly questioning their devotion to this career. And I wonder, balancing that with looking ahead and sort of a more panoramic view that you now have at this stage of your career, what gives you hope that we are going to recover from this and come out even?
I've no doubt we will recover, and there are people for whom the majority who go in to become physicians or surgeons, it's a vocation. It's what you want to do. You don't look over your shoulder, particularly at those in other professions or other disciplines who are making more money or whatever. There are stresses in every successful enterprise. I think we're beginning to be more understanding, I hope we're beginning to be more understanding of the pressures that the modern world puts on, particularly on surgeons, but I would extend that to all professions across medicine. And we have to get away from this concept of the pyramid, that we're training to a pyramid, that excellence is in the academic medical center, and that anything below that is somehow not excellent. And I love this analogy of the ziggurat, which the Sumerians had instead of pyramids, which is it's a pyramid, but it has stages in it. And that we must appreciate that a lot of our surgeons, and particularly now we need more family-friendly environments to train and to practice, that working at level 1 or level 2 or level 3, that's enough. But there should be excellence and parity of esteem at each level. And if you can get that, then you're going to get a work-life balance and resilience. And the other thing is we should accentuate the positive. I love that song, Accentuate the Positive. There's too much negativity and looking at the problems. Just think of the amount of good work that we do. I mean, it's the one complaint that you get every 5 years that really eats into you. Yes. But you don't think about the 99% of people who actually have had a positive experience. And that's what we need to develop, a resilience and accentuate the positive.
Well, that is a very positive note for us to end on. I want to thank you so much for your time, and congratulations on winning this prestigious award.
It's been a great pleasure. Thank you.